Moving on to Regional and Orthopedic Anesthesia, Part 5 for the ABA Advanced Exam. In this lecture, we're going to talk about the sciatic nerve block and the popliteal fossa block, and then in the subsequent lecture, we'll talk about the ankle block. So with the sciatic nerve block, before we're going to discuss a little bit of the anatomy first. The sciatic nerve derives from L4 and 5 as well as S1 through S3. Largest nerve in the lower extremity with a width on average of about 2 centimeters. And it's composed of two nerves ultimately bound by a common sheath, those of course being the tibial, common peroneal, otherwise known as the common fibular nerve. After passing through the sacrosciatic foramen beneath the piriformis muscle, lies between the greater trochanter of the femur and the ischial tuberosity. The nerve does become temporarily superficial at the lower border of the gluteus maximus, where you can do infragluteal approach to block this nerve. But then it descends into the popliteal fossa and supplies cutaneous innervation to the posterior thigh and all the leg and the foot below the knee, at the exception of the medial strip distal to the knee that is innervated by the saphenous nerve. So it's a nice image from Miller's anesthesia that shows you, here you have the piriformis muscle and sciatic nerve coming out from underneath that. What this doesn't show you is the inferior border of the gluteus maximus. That's kind of taken away, but that's the point right here where it would be most superficial. The classic posterior approach of sciatic nerve, the approach of Labat, is well described. The patient is positioned laterally with the leg to be blocked rolled forward onto a flexed knee. And a line is drawn to connect the posterior superior iliac spine to the greater trochanter of the femur. A perpendicular line bisecting this is drawn and extended 5 centimeters caudad. So I'll have an image of this coming up because I know there's a lot of verbiage on this slide. Now, a second line is drawn from the greater trochanter to the sacral hiatus. And the intersection of this with the perpendicular line indicates the point of needle entry. If bone is encountered, the needle is redirected systematically in a lateral or medial direction. So that's what we see here. So posterior superior iliac spine to greater trochanter and sacral hiatus to greater trochanter. And then you drop a perpendicular line from that first to this one, and that is essentially to bisect this line, and that's where your needle entry point is. Okay. And so that gets you to the sciatic nerve just as it comes out from underneath the piriformis muscle. So what artery is in close proximity to the sciatic nerve when performing the posterior technique to this sciatic nerve block? So this is going to be your inferior gluteal artery, okay? And that's going to be in the territory of the nerve when you do this block, okay? So this is medial, this is lateral, there's your femur, and this is your gluteus maximus muscle. And there you see this large sciatic nerve sandwiched underneath. This arrow identifies the inferior gluteal artery, as I said, which at this deep level of block is going to be within the territory. So you do have to look out for that when you're using ultrasound image guidance. There's a subgluteal approach, which is rather popular because the nerve is relatively superficial when you're blocking it this way. The most prominent aspects of the greater trochanter and the ischial tuberosity, which are identified by palpation. A line is drawn joining these 2 points. Perpendicular line bisecting this is drawn and extended down several centimeters. The second line approximates the location of the sciatic nerve. The site of needle insertion may be at the intersection of the 2 lines or as far as 6 centimeters distally. You can kind of go anywhere along this axis. And certainly, if you're using ultrasound guidance, you can see the nerve under direct visualization. So again, imagine where the inferior border of the gluteus maximus is. If you can additionally draw a line between the ischial tuberosity and the greater trochanter, and that should bring you within range right here where the nerve is most superficial. Again, you'll see a branch of the inferior gluteal artery in this territory. And that's what you see here. This image is very similar to the previous one with the Labat approach, and you can see the gluteus maximus here and the sciatic nerve underneath. So what is the most desirable motor evoked response when anesthetizing the sciatic nerve for a successful block? So overall, you can get all of these motor evoked response when you're using stimulator for sciatic nerve block. But inversion is probably going to be your best bet. Okay, once you're getting inversion, you are in the territory of the tibial branch of the sciatic nerve, but you're well poised with the needle to capture all the branches at this level. If you get eversion or dorsiflexion, you're way too lateral and tracking along the common peroneal nerve or common fibular nerve. It's going to take a long time to capture the fibers that contribute to the tibial nerve. You may not get it all altogether. So those were the evoked responses to sciatic nerve stimulation. And as I said, the most desirable response is inversion. Plantar flexion is the second best. But if you stimulate the common peroneal nerve, you're going to get dorsiflexion and eversion. It's really not an acceptable response. You're going to have to redirect your needle more medially, okay, to capture the tibial nerve branches. So there is an anterior approach for the sciatic nerve. I don't know how many institutions employ this approach, but it's useful when the patient can't be positioned for the classic approach because of pain or lack of cooperation. You can get initial blockade of the femoral nerve, and so technically you can block the femoral and the sciatic in one shot, in one block. So if the patient is lying supine, you draw a line along the inguinal ligament from the anterior superior iliac crest to the pubic tubercle. Second line parallel to the inguinal ligament is drawn, and it begins at the tuberosity of the greater trochanter. The needle is inserted perpendicularly with a slight lateral angulation at the point where the line representing the juncture of the middle and medial thirds crosses the second line. Okay, and so that's what you see here. This is the medial and middle thirds of this initial line, okay, and that's your needle entry site about a few centimeters inferior and lateral to that. And as you can see, if you keep going deeper and deeper, you will eventually come within range of the sciatic nerve. And so this is ultrasound imaging for the anterior sciatic nerve approach. Okay, this is the anterior thigh. These are the femoral vessels up here. Okay, and this is the lesser trochanter of the femur and the adductor magnus. This is the medial thigh. This is the lateral thigh. And they've outlined for you the sciatic nerve. They've turned the probe 90 degrees to visualize the length of the sciatic nerve from cephalad to caudad direction. So we're on our way to sciatic nerve block at the popliteal fossa. Which muscle constitutes the lateral upper border of the popliteal fossa? So in this case, it's going to be the biceps femoris. Okay, that's the lateral border, upper border of the popliteal fossa, that diamond-shaped fossa. And we'll see an image of this coming up. Posterior muscle of the thigh are the biceps femoris, semimembranosus, and tendinosus, and posterior portion of the adductor magnus. These muscles all form the upper border, the upper triangle of the popliteal fossa. Okay, the semimembranosus and tendinosus are medial. Biceps femoris is lateral. Okay, the lower triangle of the popliteal fossa is essentially the two heads of the gastroc. So in talking about this block, there are popliteal vessels that are in the territory of the popliteal nerve. And so you need to be aware of where they are positioned relative to the nerve, and we'll see an image coming up with that. The upper part of the popliteal fossa sciatic nerve lies a little posterior or lateral to the popliteal vessels. Popliteal vein is medial to the nerve. And the popliteal artery, interestingly, is most anterior typically. There is some variability in this anatomic disposition of the nerve, the artery, and the vein. Okay, the upper border of the popliteal fossa, the two components of the sciatic nerve have pretty much separated at that point, even though they may still be in the same sheath. The peroneal nerve ultimately courses down laterally. The tibial nerve pretty much descends straight down. So you can do a popliteal fossa block for foot and ankle surgery, and it's preferable to an ankle block, especially for procedures requiring a tourniquet. The components of the sciatic nerve can be blocked at the level of the popliteal fossa through a posterior or a lateral approach. But you will oftentimes need a supplemental block of the saphenous nerve because of that. That's, of course, a branch of the femoral if you're going to be using a tourniquet, especially for the medial aspect of the leg. So this is the right extremity. This is medial, this is lateral, and here is the popliteal nerve, sciatic nerve, as it divides into common peroneal and tibial. can see the artery is rather superficial, and the popliteal vein is medial to that. Here are your gastrocs down here. Okay, here's your semimembranosus / tendinosus, and your biceps femoris. Just a cross-sectional view. This is a lateral aspect of the leg. This is medial. Here is your femur and patella. And as you can see, the popliteal vessels are medial to your sciatic nerve. Common peroneal and tibial components are here. So to do the block, the borders of the popliteal fossa are identified by flexing the knee joint. A triangle is constructed with the base consisting of the skin crease behind the knee, and the two sides compose of the semimembranosus, which is medial, and the biceps, which is lateral. A bisecting line is drawn from the apex of the triangle to its base, and a needle is inserted anywhere really 5 to 10 centimeters above the skin fold. You can kind of be anywhere along that trajectory. If you want to go higher up, you'll better capture both components of the nerve together. Okay, and if you're using a nerve stimulator, as I mentioned, inversion is your best response. So, as with any other peripheral nerve block, nerve injury is a potential complication. Intravascular injection can occur, although it's pretty easy to identify the vessels on ultrasound imaging and avoid them completely. Doing this block in a patient with a previous total knee arthroplasty or vascular bypass, such as fem-pop bypass, has to be done with care. But there haven't been any reported cases of graft disruption or joint infection related to needle placement in these patients. So there you have it. We're going to do one more lecture on the lower extremity that is to comprise the discussion of the ankle block, and then a little bit of material on the neuraxial anesthesia keywords for the advanced exam. Thank you.